All right, welcome everybody. Thank you so much for joining us tonight for a really special episode. I probably say that every time, but this does feel extra special, and we'll get into the reasons behind it. But before we do that, and before even introducing ourselves, I would like to invite you for a little bit of a moment of mindfulness. So if you can all join in this moment, if you feel comfortable, to please close your eyes or lower your gaze. Take a comfortable seat in your chair. I will do it also. The feet firmly on the ground, hands on your sides. Close your eyes if you're comfortable. And take a deep breath in. And deep breath out. As you continue to breathe, I'm going to read you a short poem. The Guest House. This being human is a guest house. Every morning, a new arrival, a joy, a depression, a meanness, some momentary awareness comes as an unexpected visitor. Welcome and entertain them all. Even if they're a crowd of sorrows who violently sweep your house, empty of its furniture, still treat each guest honorably. He may be clearing you out for some new delight. The dark thought, the shame, the malice. Meet them at the door laughing and invite them in. Be grateful for whoever comes, because each has been sent as a guide from beyond. When you're ready, welcome back to the room. All right, thank you so much for taking part in this little mindfulness moment. I really enjoyed it, and we'll get to the importance of this poem, I'm sure, in the conversation later with Marta. Welcome again, everybody. My name is Solène Anglaret. I'm the host of the Inclusion Conversation and the founder of Be Beyond Borders. The Inclusion Conversation is a monthly talk show where we talk about different topics linked to diversity and inclusion. The aim for me is really to break down borders, break down stigma, break down stereotypes, and bring people closer together, one conversation at a time. And so today, as you know, we're talking about borderline personality disorder, and we'll dive a little bit deeper into this topic very shortly. Before we do that, I just want to take everybody through the flow of the conversation for tonight. So we have 1 hour together. Thank you so much for, taking an hour of your time to be with us and learn more about this topic. It's going to be divided in 2 parts. The first part is recorded and is starting now, already started. We're going to be discussing together with our guest, Dr. Marta Santandreu I. I hope I said it the right way. I should have practiced this before, Marta. We're going to have half an hour of dialogue, the two of us together. And then halfway through, we're going to stop the recording and we'll have just a genuine open conversation. Any of us here tonight is then welcome to unmute, ask questions, use the chat function at any time. And by the way, if you already want to use the chat function to say hello to each other and to tell us what brought you here tonight, please feel free to do that. We'd love to start getting to know you. In terms of the etiquette and the flow of the conversation, so we are recording this session, as I mentioned, cameras on if you're comfortable, that's amazing. And we have the live captions enabled, so feel free to use those. Use the chat, tell us about you, say hello to each other, and feel free to connect through that. In terms of mindset, this is all about connection and conversation and creating community. So do share, do engage, keep an open mind, and make sure that this remains a safe and kind space for everyone. We don't have any scheduled break in this conversation, but I do realize that this topic can be a trigger, and I'm sure that it would have been for me even not so long ago. So if you feel at any moment that you need to step away, you need to turn off the camera, or even you need to leave the conversation, that's okay. We just want you to feel comfortable and feel safe and enjoy the conversation tonight. So without further ado, I'm going to be joined for a little bit of a different episode by our guest, Marta. The two of us met, well, just over a year ago, and we are going today to be having a dialogue around the topic of borderline personality disorder. And for those who are joining for the first time, you might think, well, okay, what's different? What's the big deal? What is she talking about? Well, what's different is that usually I'm the host, so I get to do the really, easy and fun job of just asking questions to my guests. But this time I'm a host and a guest. Marta and I are going to have a dialogue, and I'm going to open up to all of you about a diagnosis that I got just over a year ago. And so it's quite terrifying, I'm not gonna lie, but I feel in a safe space. So thank you for that. And thank you for all of those who have the cameras on and are giving me smiles. It's definitely helping. So I appreciate that. So that's it for me for the introduction. Marta, would you like to introduce yourself?
Yes, of course. First of all, hello, everyone. It's lovely to see some of your faces, guys. I can see just in the gallery view. I'm just scrolling now down. I'm seeing some of your faces. So thank you so much, especially for joining us today, for being willing in learning more about what BPD entails, what is that, and of course, supporting Solène too, because I'm pretty sure that people are here also to learn and at the same time to show support. So I'm very pleased to see you all. Yeah, I just want to thank also Solène for the invitation. I hope we have fun and we reflect also on the journey that she had, which has been very effective and successful so far.
Thank you so much, Marta. And do you want to tell us a little bit more about you and your background? And also, if you can explain to all of us, what is borderline personality disorder?
Yes, so first, I'm a counseling psychologist by background, and I specialized in personality disorders a couple of years ago. I trained with British IELTS, DBT and Behavioral Tech, Linehan Institute in the States. And this is a teamwork, of course, as you can imagine. So we are a team of therapists treating a group of people and clients that seek out for help to us. So myself and the team, we're working together to make people's life worth living. Let's put it this way. So this is me, and the way that we met is basically the way that Solène has explained. So she reached out to us nearly 1 year ago, I think, 1 year ago. And I will tell you more about all of that journey later on. About your question about, I guess the definition and description about what borderline personality disorder is. It's a bit difficult to go into content about, diagnoses and all that type of psychiatry type of, terminology. So I don't mean for this session to be like a lesson of something, but just to summarize, we're talking about normally a pattern of consistent behavior. So otherwise we wouldn't call it this way. It's not a state, or it's not something that just happens contextually. Is something that we can see pervasively happening in different situations and contexts in life, when normally people show behaviors that are driven by emotional instability, normally, or something that we call mood swings and mood up and downs. Then there's difficulties in trusting, engaging in relationships, and enjoying the company of others around, because it's difficult, and normally relationships become intense and quite unstable at the same time. Then normally we find impulsivity and impulsive behaviors that would be a way of regulating emotion somehow. So we know that also part of how people will engage in certain behaviors will be part of a way of surviving, right? Way of surviving, how to manage with this overload of body sensations and overwhelming physiology that sometimes some of the extreme emotions can show for people. That would be the main domains of what borderline personality disorder presents with. Also, it's worth to highlight how normally people under this group of symptoms and diagnoses, I don't like labels too much, I have to say, to everyone. So I know that this is precisely engaging more in the stigma. That's why I'm calling this group of symptoms. So it's the normally cognitive distortions about perceptions about if people would like me, people would love me, I don't think I'm lovable, I think I'm not good enough. So it's usual for people presenting this to understand that from a specific situation, this means rejection, this means I'm not being liked, or I'm not being enough, or I'm worthless. So that would be the part of cognitions being quite perceived, not very much like factually.
Yes, I can definitely relate to a lot of what you've just said, and maybe it's worth touching on the fact that there's so much variety in borderline personality disorder, and we'll get to that in terms of there are 9 main criteria to diagnose someone with BPD, and if you meet 5, then you are diagnosed. That means there are hundreds of different combinations of diagnosis and therefore of symptoms and behaviors that are attached to each person. So for me, it was a lot of what you said around the low self-esteem and the instability of who am I, and constantly having to revisit and feel like I don't know myself. Where does this ever end? And you also touched on the high emotion. So especially growing up, BPD felt like, well, I didn't know I had it. I didn't know I had it until 1 year ago. And so, but I knew I was different. I just knew there was something inside of me that just was different. I had such strong emotions. And when I tried to explain, like, oh my God, like there's this, or this is so awful. It was like people were kind of like, it's no big deal, it's just like this thing happened, like chill, and I'm like, what do you mean chill? So this huge, vivid emotion spectrum, and also the waves, the ups and downs, and not really being able to find that kind of middle point where you can be content, not knowing really what that feels like, because being constantly dysregulated from very high to very low, and not in a matter of weeks, because I think maybe some people are familiar here with bipolar disorder, which usually is periods of depression and periods of mania that can last several days, several weeks. With BPD, the main difference is that it's minutes, sometimes seconds. So you can be like, yeah, everything's fine. I'm doing my job, like today, let's be honest, doing my job. And then an email comes out and you're like, oh my God, how dare they? How could they say this? So you can go from like joy or even comfort to anger, bursts of anger, which is another way that it showed up for me. And then there's things like being terrified of abandonment, feeling empty, feeling like you have a void inside, a hole inside constantly. Yes, so many different ways. And then like Marta described, I think a lot of people with BPD that I've spoken to would resonate with that, is we just find ways to mask, A, to fit in, and B, to cope. And often these coping strategies, like Marta said, if we're not like aware of what's going on, can be self-destructive. For me, it was around eating, especially having panic attacks. And then you obviously can have suicide ideation as well. So yes, that's a little bit about kind of how it showed up for me. And I wanted to throw it back to you, Marta, and kind of ask a bit more about those 9 traits, 9 criterias. What are they?
Yeah. So what we're doing basically, again, in mental health, we need to classify things. There's so many things. Again, just linking it with my conversation about, I don't like labels because they just encourage us to stigmatize, I guess, or we're closer to a stigma when we put things into boxes. Now, it's at the same time, dialectically speaking, right? I am aware that we need to put the knowledge somewhere to know what we're treating. So the diagnosis with that comes with the DSM-5, which is the American Psychiatric Association classification for mental health disorders. And then we have also the ICD-11, which belongs to the World Health Organization classification with mental health disorders. Hence the difference between EUPD for the ICD-11, and then we have DSM-5 for borderline personality disorder. If you have heard these 2 different names, they're just basically the same, but they belong to 2 different manuals and 2 different big institutions doing research on mental health. Now, having said that, what's the difference between using one or the other one? So ICD normally is more used by medical doctors and in clinical practice. Then DSM-5, unless you are in the States or you do research for academia, DSM-5 will be more used. That's the technical part of the conversation, right? Now, according to, I'm going to go with DSM-5, right? And basically is this criteria of 9, right? And you said you need to meet 5 out of 9 to be in, or I think it's also tricky to say in, out, right? It's also like, what was I may be in one day and out the other day, right? So that's why also it's a word to discuss, I guess. So as you have mentioned, the feelings of abandonment, the fear of rejection, of not fitting in, the odd one out in the group or in the tribe is one of the major things that we look into to diagnose these difficulties or group of symptoms. Then also we look into, of course, impulsive behaviors that may translate into, I feel it has to happen in the moment, right? So following urges, so would be less self-control, to put it some way, in certain behaviors and actions that one may have, mood swings, up and downs, and then also this translates into unstable relationships, right? Which is tricky really to trust, to stay over others. And also what you have described before is the invalidation that sometimes may happen around extreme expression of emotion, because the environment will come back with, stop it, right? Stop it right now, because it's difficult for some people really to manage the difficulties that their loved ones are going through. So that would be one of the results of what happens next. You have mentioned it too, but I will ask you, I want you to hear from you what it's been for you. So emptiness and numbness, some people dissociating sometimes, these situations of not knowing where are you have these experiences of, going out from the reality and everything, it feels not quite real, right? The anger outburst, although I have to say that not everyone over expresses anger. We know that many people will under express, and that depends on many factors and variables, I have to say. Marsha Linehan describes in her manual textbook that some people will do just under expression of anger depending on the context they grew up, and anyhow, this is a way of, again, adjusting anger to the context in whatever we are facing. Then all the behaviors may show, you have mentioned the eating, you have mentioned that it could be erratic, something, way of relating to others, or all the self-destructive relationships or behaviors. Now there's something very typical in borderline traits, which is the high rate of suicide attempts, or at least resorting to suicidality to cope also with emotion. So many times people will face extreme emotion and will learn to regulate emotion by finding hope in death. Perhaps it could be, it's on me, it's under my control, I could do it if I want. So many of these behaviors to numb the physiology also have to do with use of alcohol and drugs, which is not very much, it doesn't have to be the case. So many people have never related to that practice, others have. And then also all the strategies to resort to avoid and numb emotional pain would be harming oneself physically. That could be one of the options too. I don't know if I have missed something, but I'm interested in knowing from you, Solène, what would be the main criteria or things that you would relate to?
Yes, I think a lot of these at different times and in different ways. And when you touched on the suicidality, I think it's really important to go back to data as well. Like 7 in 10 people with borderline personality disorder will attempt suicide, and 1 in 10 will complete. So it's obviously a really challenging state of mind, as you can tell, because it's not, I don't think it's, very easy to navigate. But what really helped me, Marta, was through our sessions actually, is realizing that those suicidal thoughts, they help to make everything else look minimal as well. So it's like all these emotions are coming and we just think, oh, I could just kill myself. And all of a sudden, all the emotions are like, boom, at bay. So it's like almost like a coping strategy. And yes, for me, that was a turning point, was starting to think more and more about what would that mean? What would not being here mean? What would that look like? How would I go about it? And that's when there was the turning point, and having that crisis and calling a friend of mine who then said, hang on a minute, I have this ex-boyfriend who is a therapist. He's going to give you a call back. Hold on, don't move. And I was like, okay, fine, whatever. And I really owe so much to this person. His name is Paul. He was not able to join. He lives in the States now. He's got this jet setter life. But he spent, an hour with me on the phone and said to me, I think this is more serious than a lot of people were going through a lot of things, right? It's lockdown, a lot of people are facing very difficult times with depression, with anxiety, with lots of different things. And he was like, but what you're telling me sounds like something you've carried for a lot longer. And you've just been really, really good at hiding it. And I was like, that sounds about right. What do I do about that? And so he helped me to find the courage really to reach out to a psychiatrist and get an actual assessment. And yes, on these 9 criteria, I met most of them at various degrees. So again, there's so many, it's like almost like, and I'm so happy because I think there are a lot of people who with the diagnosis on this call, and I just want to count you all as my friends, because it's very hard to meet people like us. And so, but there are so many different versions of borderline. Like I'm sure each of us would, sit here and say, this is how it shows up for me. And that's what makes it also beautiful, I think, because we have a lot in common, which is good because we don't meet each other a lot in real life. But at the same time, we're also all like unique and different in the way that it shows up for us. So yeah, for me, when I got the diagnosis, it was a massive relief. I know a lot of people feel differently because they, oh my God, like, it's like, I'm borderline, like, what does that mean? Kind of like, because the stigma that's attached to it, but for me, it was like, oh, there's a name for it. Oh, thank goodness.
Yeah, sure.
And on top of that, there's a treatment, and there's people who understand. There are people like me who feel the same way, who've been through similar things. So how do I, get more into that? So I'd love to ask you a bit more, Marta, about this topic, about treatment. What's the recommended approach? How do people get help?
Yeah. So of course, as you can imagine, if there's diagnosis manuals, we have also guidelines about that tell us about evidence-based treatments to precisely choose what works. So there's the whole machine of research. It's been there for more than 30 years, I would say now, when a woman called Marshall Linehan in the States developed a specific treatment because she wanted to help people that went through hell, just quoting her, same way that she did. So there was a woman back in the 60s when she was admitted in the hospital for 2 years and was diagnosed with hell knows what, right, back in the 60s. And then she made it out from a mental health hospital, and she started to just do some, she was interested in recovery, of course. And then also at the same time, she started to study. She did a degree, and then she went for a research PhD. And then she was very adamant of learning more and helping people that went through the same. So then she developed this therapy called DBT, which stands for dialectical behavior therapy, that has helped and continues helping many people around the world. So there's DBT therapies and DBT treatment and services and all around the world. So the main responsible for that is Linhan Institute Behavioral Tech in the States. They're based in Seattle, Washington University, and from there they are training DBT therapists all around the world. So what this DBT training does, training is a part doing all of this, making sure that all of us, we're delivering evidence-based treatment for people struggling with these symptoms, is also providing therapy, which is an intensive therapy, long therapy. So you've been in therapy for 34 weeks, if I'm right, which is 8 months, or something like that, 9 months. So it's an intensive therapy that combines behavioral science, behavioral data, behavioral principles with influences of Zen mindfulness. That's something that Marcia thought to bring together, hence the dialectical approach. So she was criticized many times for, this is not going to work. This is not going to work, because you're combining two things that they don't mix up well, right? But they perfectly worked out, because she went to a retreat, she worked herself with mindfulness, and she realized that if we want people to change their habits and their way of facing their difficulties, what we want is we want them to learn awareness. Without awareness, there's no behavioral change at all. It never happened, right? So people that were able to approach to different levels of readiness in the stages of difficulties that they had in life, they always needed awareness before making further steps. So the DBT treatment is challenging. It's not easy, I can tell you. She will tell you more. DBT will challenge you. You will attend the skills group. The skills are learned in a group setting, and many people will have, along with these 2 hours of group every week, another one-to-one session with an individual therapist. That our main purpose is to keep motivating the client and enhancing the skills, capabilities, and also generalize the skills into the environment, because also who's in one-to-one DBT will have access to 7 days a week, will have access to their individual therapist if there's a problem with the use of the skills. It's not a crisis line at all. It's not an emergency service. It's a coaching line where we will remind Solène, I reminded Solène when she needed it, that there's a skill called X, there's a skill called Y that she could use, because we know that the best way to do so is when the crisis hits, right? When the problem happens in that moment.
Or just before.
Yeah, right. Well, of course. So we are encouraging people to reach out for us before. Otherwise, when we are engaging in problem behavior, it's too late and we cannot help anymore because the emotion is not there anymore. So that's precisely what dialectical behavioral therapy does. We also, as DBT therapists, we attend something called consultation team meetings, which is crucial for us. We support each other because, again, we may lose some perspective on something and we need to look for synthesis when we are polarized in opinions. So many times my colleagues have supported me in finding the synthesis in the dialectics when something has been missing or left out. So I would like to hear now a bit from your experience with DBT, Solène.
Well, so much to unpack, right? I saw in the chat a few people are either in therapy or even before taking the jump, kind of considering it. Yeah, for me, I mean, it was life-changing for sure. And it was interesting because I had tried therapy before. I had done psychoanalytical therapy a few years ago. I just sat there and just talked for like an hour and just cried my eyes out, and then it was over. And it's like, and after 6 months I was like, what's changed? I'm not sure. So that didn't really work for me. And so dialectic behavioral therapy was so different because for those who don't know, it's really about skills. And so you're in a group setting and you're learning these skills, and you're not necessarily unpacking every detail of your past or blaming other people for whatever happened. You're more focusing on, okay, how can I deal with different situations in a different way, in a more healthy way for me, and how can I get closer to my goals? You're always bringing it back to your goals. So yeah, for me, I found it super helpful. I was really dubious at first, especially around mindfulness, and Marta will remember this. I was like, nah, I don't do mindfulness. Like, I don't sit there and meditate. And then you saw how I started this call, right? So a lot has changed. I've appreciated, you know, the skill that mindfulness really is, which is creating that gap between the emotion and then the immediate urge or behavior that comes as a result, which may be a destructive one. So there was that. And then I think the other thing that really helped me with one of the skills, and some people on the program might relate to that, is the self-soothe. I love this skill so much. I have a lot of friends like this in my house. This is the call where we all get real, you know, and they help me because they, you know, it's the tactile element, and it's really getting back into your body. And I think that's the other thing. So one, therapy helped a lot. Two, getting back into that mind and body connection was really important for me. I went on a physical kind of health journey at the same time as therapy. I became stronger physically through physical exercise, and also a physical exercise community around it. And that really, really helped as well. Another thing that helped me a lot was books and documentaries. I don't know how many people have seen, for example, Back from the Edge, which is quite old. Let's be honest. But it's 45 minutes, and literally I've watched it like several times, and every time I'm like, oh, people like me, hello. So yeah, and books, like I just finished Get Me Out of Here, Rachel Rayland, and I listened to the audiobook. And again, it's like another story of another person with borderline personality disorder, and their journey and their challenges, and they're different, you know, we're all different, but every time it's that little comfort that you're not alone, and that there are other people that have faced similar challenges and have, you know, found a path to recovery. And then the final thing, which is something that's, you know, I've been really lucky, is to get the support of my partner, of my family. And I know I'm very lucky because I've met many people on the program and through, you know, all of this advocacy work that I'm starting shyly, who don't have this kind of support system. And, you know, that makes it really hard. And I always remember this image. I don't know if people have seen it. It's two fish in separate bowls. And on one side, the bowl is like really dirty water, and there's a little fish there, and the fish is not feeling great. And then on the other side is another bowl with clear water, and the fish is like swimming. Da, da. And the caption, essentially, I don't remember the exact word, but essentially is, you know, if the fish isn't well, you change the water, not the fish. And so that really, I think, resonates with the environment is so important, and the relationships around us are so important. And so, yeah, I'm very grateful. Actually, my parents are on this call. My partner is on this call. My sister is on this call. So yeah, I've, you know,
thank you guys
been very
for
lucky
being here. Thank you.
Supported through that. So yeah, wow, we're already halfway through, Marta. I feel like we have so much more to cover. I do want to ask, one final question
Yeah.
before we stop the recording and have that more intimate chat with everyone. And that's around, it's a couple of layers to it. One is, there's a big stigma around BPD currently. I didn't know that when I got diagnosed because I'm French and I had no idea what BPD meant. So I was like, oh, cool, there's a name for it. Like I didn't, and then I started researching and, seeing like people think we're psycho, we're manipulative, we're all these horrible things, which we're not. I mean, we're struggling enough. Oh, yes. Sorry, someone put in the chat, The Buddha and the Borderline, loved that book, absolutely devoured it. So do check it out if you're interested. But yeah, so there's a massive stigma, which, in my opinion, like we're struggling enough with our emotions, our inner life, and all of the stuff. We don't have time to be your psycho or something. I don't get it. But anyway, so that stigma, and then also the idea that people with BPD can't recover, won't recover, is still present in research, is still present in professionals' minds. I mean, you meet therapists who think that that's the case, therapists who don't want to share their diagnosis with the patient and things like that. So around that, around the stigma and around the idea that BPD can't recover, like, could you share a little bit your views on that? And then I'm happy to share mine as well.
Certainly. I'm aware of time. I'm going to try to be concise but descriptive with your questions. So about the two questions, I'm going to go first with the stigma. So one of the things that doesn't help at all is, well, diagnosis is the label, right? So label, as I said before, I'm not going to repeat that, is one of the things that doesn't help. Then number two is also the other names that borderline can take. And the one that normally hurts the most is manipulation and manipulative, which what we do, DBT therapists, is we look into the situation as every function does not prove intention. And that's the sentence that I would put there. And that means the reason why you're doing what you do does not prove that you are doing this to hurt me or to get something, right? First thing. Now, second thing, if we looked into the environment and how an environment can become hopeless in learning people or teaching people or supporting and validating someone in dealing with extreme emotions, we will understand that the person suffering with extreme emotions will do whatever it takes to get to that validation. And this is not to get what I want. This is just to precisely someone telling you, I can see that today is a very difficult day for you, right? But people or parents coming back late from work or not knowing precisely, having the skills how to manage emotion, which understandably many people perhaps are not skilled in doing that, can be sufficient to create this invalidating environment. Hence, the person learns to go a bit extreme in, look, I need validation, I'm growing up, and this is the way that I'm feeding myself up. Milk, water, food, and that, right, while growing up. So there's many factors that intervene here, but the way that we look into extreme behaviors in DBT is methods of surviving and getting, of course, is absolutely ineffective. Someone will tell, let me discuss that. Is that effective? Of course it's not, because you're just getting things worse, right? So in DBT, people learn that stop, that doesn't work, stop it there, tolerate distress, and learn to communicate what you want effectively in a different way. Of course, we're talking and teaching to people that have done this for years, and it's not that easy. That's why the treatment is so intense and long. First thing with the stigma and manipulation and everything. About the recovery, I think the best example is Marcia Linehan herself, which made it out from hospital after being diagnosed with many things. Finally, it looked a lot like BPD. She has a memoir that I will recommend you all, which is called Building a Life Worth Living, which is this book. So anyone interested in learning more about her story and the skills that she developed, you can find this. So she tells her story, and she decided to write this book because she never said anything, but then one day she was approached by someone saying, it rumor has it that you're one of us. And then she decided to just say, well, let's share this with the world. And one of the first things that she says there, precisely with your question, is, if I can do it, you can do it, right? So I think this is the answer to your question. And you think?
Mhm.
Great.
Well, yeah, it's really interesting because for me, I have this, by the way, this is purely my personal opinion. So I welcome when we stop the recording any thoughts as well on that. Personally, I feel like I will not recover because borderline is part of who I am. It's not everything that I am, but it's a part of me. And so it will remain a part of me. I can better manage it. I can totally better live with it. And there are superpowers that come from it, by the way. We haven't even touched on that. I mean, we're empathetic, we're creative. There's lots of great stuff that comes with borderline. So I am in recovery for the rest of my life. And I choose recovery every day. Every day I get up, and some days is easy, not too many days, some days not easy at all. And every day I have to remind myself, I choose recovery. What does recovery look like today? You know, is it a day that I need a certain skill to use? Is it a day that, you know, I need to use self-soothe or some other strategies, distress tolerance, to help me, you know, get through it? And so I have that theory in my mind where it's like, I'm not recovered, I'm in permanent recovery. And on the stigma side of things, I mean, wow, like when I discovered how much stigma there is around borderline, I was like, terrified, hence also being quite terrified doing this today, like knowing that my employer has no idea and suddenly I'm going to be so open. But at the same time, I just think like, it's all of these topics around inclusion, diversity, mental health. We need to talk about it, because the more we talk about it, the more we show the world that we are here, and, you know, we are also great people. We are great contributors. We can, you know, and I don't know why I said also. There's no also in that sentence. We are great people, full stop. You know, we can contribute so much to society, and bring different perspective from this extra emotionality and this different lived experience that we have. So yeah, that's what brought us here today, and we have definitely completely smashed the clock. So I'm going to just close the recording part of this. So just bear with me, everyone. I will just share one quick slide. This is for anyone who's watching the recording of this before we end this part. So this is just to say thank you to anyone who is watching the recording on replay. We have some future episodes coming up. In June, we're going to talk about dyslexia, and we're going to talk about where is diversity in diversity and inclusion, because most people in this space are white female, turns out. And in July, we're going to talk about home. Where is home? And looking for a path to belonging, which I think a lot of people that I've met anyway that have the borderline diagnosis will identify with that struggle of fitting in versus belonging, and how that shows up in our lives. If you want to, you can follow on @BeyondBorders. You can also subscribe to the newsletter on beyondborders.com, and you can watch previous episodes. So actually, this is episode number 6. So we've talked about lots of different other aspects of diversity and inclusion. And I kind of have a feeling that there'll be a part 2 to this, because we definitely haven't covered everything. So that's it for the recorded part. Thank you, everyone who is watching, and hopefully see you live next time.